like to welcome Professor Heiko Spallek to chair our panel discussion this afternoon.
Thank you, Melanie. May I ask the panelists to come down already? That would be very nice. And first I want to thank David to bringing up a dental example, so that's really important, so thank you for that. So traditionally, as a panel facilitator, I'm supposed to read the bios of the panelists until your eyes glaze over. I always find when I'm sitting in the audience that this is a very ineffective measure of introducing everybody. So I want to do this a little bit differently. I want to ask each of the panelists to introduce themselves and talk about their role in 1 minute. And I want to remind the panelists that 1 minute is the thing with the 60 seconds in it. So please stay short. Why don't we start? Tim, you want to go?
Okay, so I'm Tim Shaw. I'm Professor of eHealth at the University of Sydney and Director of Research and Capability Building in the Digital Health CRC, particular research interest in how clinicians interface with information and data to change their practice and also new models of care.
Thank you.
Hi, I'm Felicity Gallimore. I'm an obstetrician and a gynecologist. Over the last few years, I've become interested in clinical informatics and now have a foot very firmly in both the digital and the clinical world. Along the way, I have become interested in trying to help with the problem of trying to release data and have become involved with the Data Sharing Accord, developing it to try and help us release data from information services across Sydney Health Partners.
Hi, my name's Melissa Baysari. I'm an associate professor in digital health. I'm fairly new to Sydney University. I've only been here for about a year. My research area is in evaluation of information technology. I have a background in human factors, so I'm really interested in how we can optimise these systems to support workflow. I also have a role here in embedding digital health education into our undergraduate professional degrees.
I already have one. Hi, my name is Naseem Ahmadpour. I'm a senior lecturer in the School of Design. I research interaction design, human technology interaction, and basically mostly thinking about how we could create and design systems that support healthcare, and well-being. Part of that is how to create better ways for people to interact with clinicians, for clinicians to train in new and better ways, but also how to create technologies that could support people in self-care and well-being.
And I'm Andrew Black. I'm the director of the Living Lab for Health and Wellbeing at Westmead. And I guess I'm trying to do something along the lines of what Chuck was describing first up this morning, and also somewhere between what David was describing. So instead of a living wage for health, a living lab to build and enable the kind of infrastructure that Chuck was talking about for a living, learning healthcare system. So the enablers to bring all of the stakeholders together, community, health sector, university, government, industry, facilitate those conversations at the beginning to understand problems. How do you then test solutions in that environment, evaluate, and have the kind of data framework around that to understand what you're doing, collect insights, and whether what you're doing is working. So that's what I'm doing.
Thank you very much. We will open this up for the audience in a moment, but I will take the prerogative and ask the first question to the panel. Interoperability and plumbing and platform came up today quite a few times, and I agree it's probably one of the biggest challenges in the health IT space. Professor John Halamka, president of the Mayo Clinic platform, was recently in a blog reflecting that his Google Home platform can securely control locks, lights, thermostat, cameras, mobile devices in his home. So what do you consider the platform of the future of health information in Australia? Will it be delivered through My Health Record? Will it be delivered through Google Cloud Platform, Amazon services, or an intelligent system of interconnected fax machines? Maybe not the last one. But who will monitor it? Who will manage it? And who will be the stakeholders who actually govern the information? So I don't want to put you on a spot, Felicity, but you were part of the data accord. Do you want to start answering? And then everybody can chime in.
It's a long question. I think with the technical part, I might have to hand that over to somebody else as to whether we belong on the Amazon or the cloud or Google. But I think with regards to who should be running that and putting their ideas into it, it comes down to having that combination where the clinicians are trying to bridge the gap. And it's a bit what David was saying is you need to have the clinical input, you need to have your clinically enabled ICT people, but you also need to have your digitally enabled clinicians, and everybody needs to be able to work together to try and find that way to move forward. At the end of the day, we need our patients to get better care. There is an enormous amount of data out there, and our main problem seems to be actually getting hold of that data so we can use it.
Yeah, please.
I'll say one thing. So I'm not sure it's as you can make it as simplistic as a single platform. I think it's been said a couple of times, Robin, right from the beginning with Robin, that it's a complex system, and I don't think there's a single solution. I've had this unique view for the last 2 years being in the CRCs. We've been bombarded with people sending us platforms and products, and from Amazon to Google to smaller groups. I think there's probably going to be a collection of different organisations that come together. I do think we're at this interesting tipping point where health is being left behind. A lot of the traditional health is being left behind and being kind of taken over a little bit by these other organisations, much more nimble, can link things much more easily, have thousands of data scientists when government has hundreds, and that kind of piece. I don't know quite where it's going to go, but I don't think it's going to be a single like Siemens platform and that's it. But I think the private sector is absolutely going to challenge government in care, particularly in chronic disease. As soon as you move outside of the acute care sector, then it's kind of open. Like I said before that I have AF, atrial fibrillation. I can do a read on my phone and send that to be read overnight by a cardiologist in the US for about the same price as the gap I pay here for seeing somebody. So I think this is the kind of disruption that's coming, and so I don't know what the answer is going to be. Not a single platform, but there's going to be a lot of players in there.
Anybody else?
I was just going to make a comment. It's a little bit to David's point about retail. One of the challenges here is this dichotomy between the value of health and human life, and the sort of social dimension of that, with all of the money that floats around in healthcare and these private drivers that are there for people to make money out of the system, right? There's a huge amount of money, and everyone's eyes are lighting up with this age of technology about the opportunity to make more money out of the system as well as deliver health outcomes, and I think there's a pretty blurred line between those two games. And this piece about data is kind of right in the middle. So who owns it, or who looks after it, or what have you? One of the challenges is getting out of the specialised lockdown systems for data and getting that into the open, so that everybody can have access and you can get the outcome that you want, rather than someone trying to make $1 in the back.
Thank you. So let me ask one more question, and then I will shut up and hand over to the audience. So there was a lot of talk today, I think, about implementation of digital health. Enrico talked about the last mile. Patty talked yesterday about burnout of clinicians. And I think there's a lot to say about how we interface with technology. Elon Musk recently said that in the future, we will have to find a better way to link humans to the machines if they don't want to be left behind. So what opportunities do we have in healthcare to merge more the biological intelligence of the clinician with the artificial intelligence and digital intelligence? And just to be clear, I'm not talking about the merging of humans and computers like the Centaur. We'll talk about that next year. I'm really more thinking about the poor interface which we have. I think a clinician sitting at a computer and typing is probably the slowest and the most expensive interface and data transmission mode we have. And maybe that's a question for our designer. So,
Yeah, okay. Sure. That's a very good question. And I actually know for a fact that we have in the audience people right now thinking about AI machines and conversational agents to help out clinicians to scribe information. But we did a small project last year to look at how people interact with voice user interface, just as an example of that. And it was very interesting because we have all these different interfaces around us. We have our cell phone, we have our computer, our laptop, tablet, and we also have these conversational agents that are going to collect information. And we looked at what would take for people to pick the voice user interface. And there were not that many instances. So it's not just that we have the possibility or the capability of building these machines and these interfaces, but it's also about how we are making it people's first choice and how we are making it easy for them to use and how that's going to fit into their way of doing things, their rituals of doing things, and the way that is natural. And yeah, I think that's probably the answer, human-centered technology design.
I might just add to that and say that maybe we need to think about what's being documented and whether it's necessary to be documented, and should we be simplifying what goes into these systems. So coupled with that, we probably need to think about how data is used, and if it's not used, does it need to be collected?
I might add to that as well. I think we've always written notes as a doctor, whether it's been writing on a paper, and part of that act of writing it or typing it is that you are distilling through your mind what you're going to do. So there is an active process where if you're talking or you're not actually having to apply any other process to it, you're almost removing some of the thought power that is going into your decision making. So that would be one thing, is I wonder if that's why maybe the voice activation is not working so well.
Yeah, I agree.
And the other part is, I think maybe we should also be thinking very hard about some sort of minimum data set, where if we were writing paper notes, we wouldn't be writing on one piece of paper and then going 5 pages further, writing some more on a paper, going back another 3 pages and writing something else. We would be writing a succinct note that would have what we feel is the most important information, and that's all that would be recorded. And I think perhaps in this digital age we are tempted to, or forced to put too much data in that is perhaps not as useful as it could be.
Thank you very much. So I think the audience had plenty of time to think about questions for our panelists. So who wants to ask the first question?
Thank you, and thank you very much for today. Great meeting. Just thinking about the use of data and where we're at right now in digital health. I know there's a group in the UK, Use My Data, which I think is a group of patients and members of the public really pushing the mantra, take my data, show me the benefit. Let's acknowledge the risk, but maybe the benefit is higher. What do you think the value proposition is now that we could establish in Australia to really boost use of data or release of data from the general public?
I think this is fundamentally the problem we've had with My Health Record, that we haven't demonstrated that return on investment to the society of the value. It's been, I think My Health Record has enormous value potentially, but we haven't, it was kind of a give us all your data and we'll look after it and we'll use it for something in the future. So I think we need to come back to showing those use cases where we can demonstrate value. I think the other challenge is with My Health Record, there's probably not everybody in this room needs a My Health Record. We need the data, but there's particular clusters of groups that really do need that data more. People like myself with congestive heart failure, my data probably does need to be used and shared more broadly. So I think we need to find those demonstrations and actually demonstrate that value. I think is an absolute core thing, and I think there's a swing towards that. There are great examples internationally. We're working with an American company that accesses all the Medicaid data sets in the US and is already doing this population health outreach. So instead of, we've got fixated on population health management being on de-identified data sets, which is great for profiling and tracking and planning, but you can't reach in and touch the person you found's got a problem. So I think that's the next shift we're going to have, to where the data we give up is not going to just be used for research and planning, but actually somebody will tap you on the shoulder and say, hey, look, we found something in here you might be concerning, you need to follow that up.
Next question.
What you just said, Tim, made me think about what if it's my employer saying, hey, I see that you had this test, or I was very surprised when I moved here and listening to people talk about My Health Record and saying, I don't want my surgeon to know everything about me like Big Brother. That's a very different way of thinking, and I guess it goes hand in hand with my surgeon's part of the government. versus, I don't know, at least in the US, my impression is we love our physicians and we want them to know about us, but I could be biased. How do we address these fears of the public? I feel like it's a big thing that we all need to work together on, because people know about the fears and the dangers, and they hear those things, but they don't hear about what's being missed and the possibilities, and then what's happening when people are sharing their data. And could we do some kind of national, advertising campaign that's education based on this?
Yeah, I agree with that. I actually have colleagues in Scandinavia, and they were shocked at the idea that people wouldn't want to share all their data with everyone. I mean, that's just done. But I think it is marketing. I think it is communication. I think there is a general distrust.
I don't think we've had a social conversation as a country around this. We've just had the whole opt-in thing and opt-out, and it's just become problematic. And I mean, you haven't been here long enough, but we also had this Australia card thing a number of decades ago now, I guess, which kind of set us down this path where everybody rejected that firmly. I come back to, again, I think we've got to demonstrate the value. I mean, if you've got cystic fibrosis or something like that, it's clear you want to share your data. So I think we have to have those test use cases where we really demonstrate that. Your asthma example, it's obvious, if you've got asthma, you want everything in that. Somebody that's got asthma, or a mother or father of a child that's got asthma, would support that. But if they said, we're going to capture all this data about you and not say what it's for, that's the problem, I personally think. I don't know, Andrew?
Yeah, I think it's probably on two levels. I mean, like you were saying about the Australia card, there's my opinion at least, in this country, there's a lack of a kind of grown-up conversation about data and science and evidence and the use and value of it, and that manifests in all sorts of areas, not just health. You just have to look around politics, and there's this gap into politics. And I think then the challenge is that we don't try and bring society along with us when we have these evidence-driven things. We kind of gloss over the details, and we don't actually try and do the education piece at the same time. So I think being clear about specific cases and the value of doing this, and kind of back to the previous question, I mean, there's every bit of value from the walk from the doctor to the pharmacist and not having to repeat yourself, or, the really basic things, all the way through to then better health outcomes at population levels and understanding, consequences of things and connections to all sorts of other kinds of data sets. And it's one of the things we haven't really talked about today is the opportunity to connect health data and outcomes to all sorts of other environmental data that we might be collecting or interested in. Again, we look at fires and air quality and stuff like that, socioeconomic data and demographic data and stuff like that. So there's a way in which you can get even more complex but more interesting, and I think add even more value to individual understanding of health and health outcomes, and trying to talk to people about that in particular kinds of ways and sophisticated kinds of ways, I think would actually help in the conversation rather than just glossing over that.
One more question over here. Thank you, Andrew.
Just in relation to this conversation, how do we build trust? I'd like to ask the panel for the community, because I think it's a lot of why my health record didn't work is because of trust, and would like to just have opinions on what you think of how we can build trust and what's needed.
Maybe I can start talking about that. So it's really interesting when you mention Scandinavia and that people are willingly sharing information. Information is very free in Scandinavia. One of the things they've done, I think, well, is that they've built that into their culture and into the culture of innovation, but also the culture of the way people live as citizens. They have assimilated really well, I think, the concept of co-creation and participator design, value-sensitive design, to bring value in the process of innovation. I think that builds trust. I would trust something that I've been part of building of. So I think that perhaps is the first step to create situations where people have their voices heard and they know they are part of the solution, and not just basically they have agency. They're not just giving up information, but also they know they are part of that scenario. I think that's one of the reasons things like citizen science platforms and initiatives work. People know they are contributing to a great discovery or a great solution. So I think that may be something to think about.
I was just going to go back very quickly to Chuck's learning health system, right? So if everything is built on communities of learning that are based in community. Just have that cycle going from the ground up, but obviously getting to the middle and the top. The idea that it's all based on communities and communities and communities at different levels of scale, then I think that's a great way to start building that trust from the bottom.
I think another thing is if you look at GDPR legislation, that is the data legislation in Europe now that puts ownership of that data firmly in our hands as consumers. I mean, I think there's a number of countries now that are looking new ways of actually doing consent, much more on the fly and rigorously. So Israel's going that way, for instance. So within the CRC, we're looking at new models of kind of frictionless consent where if somebody wants to use your information for a certain purpose, it might pop up on your phone, just like when you're doing your e-banking and say, these people want to use your data, are you okay with that? And I think if we start to do that, it also builds trust so that people understand that they're part of, it's a bit like you were saying, part of that decision making. So I think we need new ways of how we actually communicate that people are going to be using that data.
Any other question over there? One more question.
As you're talking, I'm thinking a lot about health literacy and how that might really help. And I'm also thinking about political literacy as well, but that's another discussion. If we looked at health literacy, who would be responsible? Who's going to take that on in terms of helping people really understand what the decisions they are, helping people to make more informed decisions and feel like they do have that agency?
Tough question, but I'll just add into the mix, what about eHealth literacy as well?
More questions.
It's a key question.
I think education.
And there's terrifying data. I mean, there was some English data. I can't remember the numbers, but it's like 40% of people in the UK can't calculate a Panadol dose for their child off the back of a packet. I mean, there's things that are really frightening. So, I mean, I think it is a real problem that we get a serious divide, and that digital technologies don't actually increase that divide and make people that are health literate better and people that aren't worse, when we know, in fact, many of the people that are likely to not be health literate are probably going to have a higher degree of burden with chronic disease and so on. So it's a key thing. I guess it has to be societal. I mean, it has to be part of what we do as a society to make sure that is done, and it has to start at a young age. I mean, it's much harder to make somebody that's 30-year-old health literate rather than taking somebody through that process. But we have experts. I don't know if there's anybody in the audience that's expert in health literacy. Possibly at the back? Well, there you go, great.
Our whole group. So there is research being done on different ways you can upskill patients and consumers. So you can teach these skills even to adults in TAFE programs and things like that. But the first place to start, probably from most people's perspective here, is only 1% of health information that's online is understandable for people with low health literacy. There's heaps that can be done just in the basic way that you present the information. And there's a bit of work being done on dynamic consent platforms, which I think that's maybe what Tim was talking about, where you can transparently explain to people how their data is being used. They can opt in or out, depending on how you set up the system. But you can set all that up in a way that it meets guidelines to meet the needs of people with lower health literacy. So that's actually quite achievable, whether it's from the information point of view or from the upskilling point of view.
I would also add to this conversation that I think the issue of health literacy, I think it's not just the responsibility of the person who's supposed to become more literate, but also on designers and those who innovate and share that information to think about how we could make it easier for them to acquire that information. So it's not always about people changing the way they learn, but also for us to design things in a way that is easy to learn.
So I sense the questions get increasingly more complicated, so let's maybe stop here. And please give a round of applause to our panelists.